History.
Sunday night at 9 on MPT. Programs on MPT are made possible by our members and the following.
Clarent, combining human intelligence and technology solutions to combat fraud, waste, and abuse. For 45 years, Clarent has been dedicated to protecting the quality and financial well-being of the nation's most important programs. Learn more at clarent.com.
African Americans are disproportionately affected by Alzheimer's disease. Risk management, early detection, and treatment are key because the disease often goes undiagnosed. To learn more, visit the Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research website.
Boutique Air.
State Circle is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you.
Connecting Marylanders to their government. This is State Circle.
Good evening. Welcome to State Circle. We begin this week with a positive trend interrupted. In the face of the rapid spread of the COVID Delta variant, the CDC is telling more people to wear masks, and unvaccinated federal workers are being told that they will face frequent testing. The percentage of Marylanders testing positive jumped from about 0.5% at the beginning of July to near 2.5% as the month ends. Our newsmakers this week, Dr. Steve Evans, Chief Medical Officer at MedStar Health, and Maulik Joshi, CEO and President of Meritus Health in Hagerstown. Thanks to both of you for being with us. I'll start with Dr. Joshi. I know you are asking staff members to all get vaccinated by September the 1st. Do you have any idea where that percentage stands now?
Absolutely. Thank you again for the opportunity, Jeff. So we started around 60+% a few months ago, and now we're up to 75% of all of our employees. All new employees have to be vaccinated by August 1st, all current employees by September 1st, and our medical staff is leading the charge at about 90% vaccinated. So we are on our way to do what we need to for our community.
Are you getting any pushback on that?
You know, with anything, there is pushback, but for us, it's a simple message. Our mission is to improve the health status of our region. We are the largest employer in our region. We're role models for health. So this is something we have to do for the public. And so I think with that, everybody's rallying around it. We want to protect our healthcare heroes and our community.
Dr. Evans, how about at MedStar?
Yeah, thank you, Jeff, and thanks for the opportunity today. So we, much like all participants within the Maryland Hospital Association, fully support and endorse the idea of mandatory vaccinations for all of our associates. We are, like the majority of hospitals and healthcare systems around the country, waiting for the FDA to lift the emergency use authorization and make it a full biologic license application. We anticipate that sometime within the next 6 weeks, and at that point, we will then put out for a mandatory requirement for all associates contractually obligated within our system to receive the vaccine.
Did that come from the legal department, or is that something that you think maybe has been a barrier to some people getting this, that they perceive, despite the millions and millions of doses out there, that it hasn't been fully vetted?
So I think I would characterize it as we have a sophisticated community that looks at the process before and after related to emergency use authorization. So for Pfizer, Moderna, J&J, they've all submitted their applications. The applications have just been completed. The FDA then goes through the process. And I think that the world still looks at it, even though this is not emergency use, they are trying to make a personal decision around this, Jeff. And so I think for many people and many industries and many schools are waiting for the EUA to be lifted.
You have a large group of hospitals in the Baltimore area, the Washington area, Southern Maryland. What have you been seeing in terms of trends with COVID patients? Obviously, the trends have been good the past few months. They have reversed over the past few weeks, but from relatively low levels. Is that what you're seeing in your institutions?
Yeah, so the numbers are still small, Jeff. We haven't, it's not like it was even 8 or 10 weeks ago. It's a small uptick. So we are seeing a small increase in the number of hospitalizations and the number of ICU beds. But even to give you context across our entire system, we only have about 50 patients who either have COVID or potential patients under investigation. And so it's a very small number compared to where we were peaked out before. I would say that not dissimilar, I'm sure, from what Meredith, the hospitals are very, very busy. Our emergency rooms are very busy. The volumes are up significantly, dramatically larger than they were last summer, and it's not COVID related.
Dr. Joshi, what are you seeing in Hagerstown?
Yeah, Jeff, so not too long ago in January, our 300-bed hospital had 100 COVID patients, and our positivity rate in the community was 20%. We hit 0 a month ago, which was terrific, but we are creeping back up. We're still below 10 COVID positive patients in the hospital, but as Dr. Evans said, the volume is increasing dramatically. Our emergency room volume is up almost 20% just over the last 3 months. So people are coming. I don't know if, again, they were pent up and ready to be seen. We certainly saw so many by video, but they are coming in to see us. And the other thing I would say is, Dr. Evans noted it, I really have to give the Maryland Hospital Association a lot of credit. As a state, all of us saying we are going to get to this mandatory when it's appropriate for our own organizations. I think that will make a big deal. As a doctor of public health, that's what we need to get to this herd immunity.
Let me turn to your public health expertise for a minute. Washington County in Western Maryland is among Maryland jurisdictions one of the lowest when it comes to vaccination percentage. What do you see in the community? What are the barriers to getting more people to get the shot?
It's a great question. So we were one of the first to get our seniors vaccinated at 70%. But then the rest of the community has taken a while. We continue to work getting access to anybody who needs it, to the underserved. We have a pop-up vaccine clinic every single day in some part of Washington County. Our number one best places actually today to get vaccines, AC&T and Sheets. The gas stations are being our best places. So I think what we're seeing is there's still hesitancy based on all the things we know about misinformation, not understanding the science, worried about side effects. There is refusal. Our job is to keep educating, keep pushing, keep seeing people like them getting vaccinated to push the message. But this is people's beliefs that we have to work on.
And I got vaccinated the moment I was eligible. I'm sure it's the same for you. One of the things we hear from people who are doing this on the street outreach, whether it's at Sheets's or somewhere else, is that young people in particular, who tend to feel like they're invincible, when they get the vaccine, they're not doing it for themselves. They're doing it because they don't want to get their grandparents sick. And one of the concerning things about this Delta variant, which seems to spread more easily, doesn't seem to have a higher mortality rate, but it seems like you can catch it, maybe asymptomatic, even if you're vaccinated, and you can give it to your grandparents. Does that make it a tougher sell?
I think you just said it right well, the grandparent story. It has to be, if you want to get back to normal and seeing the people you love, this is the right thing to do. I'll let Dr. Evans jump in. The one thing I have to say about vaccines, we're in the middle of it right now, but in a few years, we're going to look back and say, wow, this really was a miracle. This is at the level of penicillin. When you think about 95 to 98% of people in the hospital are unvaccinated, those are staggering numbers. So it works. And so I think we have to continue to push the people like you and to see your family and loved ones get back to normal.
Dr. Evans?
Yeah, I think that the big story here is what does influence the individual for making a decision to be vaccinated or not vaccinated. And the data is pretty clear. Unfortunately, they're not going to listen to politicians. They're not going to listen to their family. the data on this is that they listen to their physician. And so the more we can connect them with their physicians, either through community health workers or mobile vans that we use within MedStar Health, or even through a digital platform that puts them in connection with their physician so that they can have a conversation and be educated around what are the pluses and minuses related to a vaccine? What are the upsides and downsides? Talking about it and having a clear understanding of the real protection of the vaccine, that's the conversation that needs to occur.
It's interesting that you both report that your hospitals are really busy. I was going to ask if you're back to pre-pandemic levels, or is it even higher than that? And is it the idea of deferred care? I know, Dr. Evans, you're a surgeon by training, and I know, for many conditions, you want to see people early in the disease, not late in the disease. Are you afraid people have been putting off follow-up care or just gone to the doctor with some symptoms?
It's such a good question, Jeff. We originally thought there was a pent-up demand in 6 months ago. And so we saw it after we got through that big surge and people were holding off and we were shelter in place. And then we saw all the orthopedic cases that were semi-elective came back in. This is not that. This is now really, I think, people recognizing that healthcare is a priority for them. The number of primary care visits, the number of people that are seeing their surgeons. This is different. And Malik is exactly right. It's broad-based. All of our hospitals are seeing increased volume, and it's no longer pent-up demand. It's people recognizing that they've just, for many of them, have gotten through the biggest healthcare crisis of their lifetime, and now they're sort of taking a different second look at how healthy they are and the need for healthcare.
What do you gentlemen think happens this fall when people are back indoors, cold season, flu season, on top of the remnants of the pandemic? What does it look like?
From the public health perspective, I'd go back to, unfortunately, the same message we say. Wash your hands. Let's not lose sight of that. Wear a mask as appropriate. And of course, watch your distance. We have to follow the tried and true public health ways to keep us where we want to and get us closer to normal. I think we're all working towards vaccinations because that is critical to herd immunity, and we have to get there to stop these variants.
So it is interesting if you look back just retrospectively to last winter, Jeff. Last winter was the lowest number of flu events and tuberculosis in recorded history in the state of Maryland, and many other states had the same experience. If we could get individuals to embrace the idea of masking for those at high risk in the age categories, and also hand hygiene, like Malik said, that would be a really good thing for Marylanders. I would say that most of the models would suggest that COVID, even with Delta variant, will quiesce by the time we get into late September, October, and then we'll see what happens. I don't think this disease is over. It's here to stay, and it's simply us how we manage it, and hopefully we won't have major global outbursts that create new variants that push us to the limit. That would be the hope for the future.
I do think anecdotally, I'm seeing more people wearing masks. I'm not, Dr. Joshi, seeing more people wearing masks correctly. Maybe give us a thought or two on how you're supposed to wear the mask.
Yeah, as we've talked about, the mask goes over the nose. Of course, it's not just the chin, and it's got to be covering, and you want, again, enough protection for yourself and for everyone else. I think, the other point in all of this is we're all in this together. We really are, as a state, as a country. And so sometimes these numbers can lead you to beliefs that aren't true. So even if we're 80% vaccinated as a country, if there are pockets that are 30, 40%, we're all at risk. And that's why it's really all of us taking care of each other. And I think from a community approach, that's what we're all trying to do. We're here for each other. Let's get vaccinated. Let's do the right thing so that we're all doing the right thing.
Good place to leave it. Dr. Joshi, Dr. Evans, thank you for your time.
Thank you very much.
Now, MPT's Salute to Veterans, Nancy Yamada introduces us to a Baltimore-based nonprofit dedicated to ending homelessness among former service members.
I need the community at large to put me out of work. I need to go start looking for a job myself. But in order for me to do that, I need to make sure there are no more homeless veterans in the nation.
It's a lofty goal considering there are 27,000 homeless veterans around the country, according to Jeffrey Kendrick, the executive director of the Maryland Center for Veterans Education and Training, or MCVET. Their 200,000 square foot facility in Baltimore aims to serve them.
So our mission is very simply to find and identify who these men and women are and to provide them a vast myriad of services to address the issues, number one, that made them homeless. And then number two, providing those services that will culminate in employment and eventually housing.
Between their emergency shelter, transitional housing, and single-room occupancy units, MCVET has 200 available beds and countless programs aimed at helping, healing, and self-sufficiency.
They can stay with us for up to 2 years, but we provide meals, we provide clothing, we provide master-level social workers that are case managers that provide services for them. We provide mental health treatment. We provide drug and alcohol treatment.
26 years after opening their doors, the folks at MCVET are well aware that their veterans' success hinges on getting to the root of why they became homeless to begin with.
I felt like unworthy. I felt like my life was over. I actually had a death wish. I didn't even care if I died.
Veteran Willie Baker Bay counts himself among the success stories to come out of MCVET after 20 years of battling an addiction to crack cocaine and going in and out of prison. He's turned his life around.
I give classes there. I do a whole lot for that program because that program did a whole lot for me, right? And they sent me to school. I went to college. I became certified as a personal trainer, health and fitness instructor, and now I'm a peer support specialist. I work for the Mayor's Office of Homeless Services, and I'm doing real well.
Kendrick knows that housing is as stable as one's employment.
We do have a job development section that is right now offering IT training, culinary training, driver's education.
He hopes more companies will see the value of giving veterans a chance.
Veterans will show you that they have a can-do attitude and are very much self-sufficient and will continue to make sure that a job is done completely before they walk away from it.
I'm Nancy Yamada for State Circle.
Now the University of Maryland School of Pharmacy has graduated its first students in a new master's program in medical cannabis science and therapeutics. Joining us now are Katrina Almonte, one of the first graduates, and Dr. Leah Serra, who is the program director. Thanks to both of you for being with us. Dr. Serra, if I can begin with you, tell us about the program, its components, and its objectives.
Sure, and thanks so much for having me. This is a 2-year part-time Master of Science program, and it's intended to provide a comprehensive foundation in cannabis science. So this program includes classes that teach about the pharmacology of the cannabis plant and the chemistry of the cannabis plant. We teach about different formulations of medications that can be made, as well as the evidence behind the different therapeutic uses of cannabis and the laws and policies related to medical cannabis in the United States.
Ms. Almonte, what drew you to this program and what did you come away with? What do you think the most important things that you learned were?
Yeah, so the answer to your first question, what drew me to the program, my background is highly professional. So I have 20 years in the military, and the UCMJ's policy is zero tolerance. So coming across cannabis, I had to find a program that was equally professional, that frankly would not mar my background and all of the hard work that I've done. And this program, Dr. Serra, she does a great job explaining it. But just to go through the program, one key factor is one of the factors that brought me in was that it's human focused. It's not plant focused. So you're learning about the plant from a very human perspective. So all of the pharmaceutics and all of the pharmacology regarding cannabis, you're learning about that from a very human perspective. And so that's the sort of understanding that I'm walking away from this program. It's not about learning about cannabis from a plant in the ground, but also, you know, this very human focused.
I have to ask, what do you intend to do with this first of its kind degree and all of this knowledge?
Help veterans. Listen, my background is military, and it's important for me to give back. Okay, so one of the last professional roles that I held in the military was a chaplain. I was an Army chaplain candidate. I worked with soldiers. They had all sorts of conditions, but PTSD was a primary condition that I saw over and over again. And after learning that cannabis is an effective treatment modality for veterans, you better believe I'm definitely focused towards helping veterans with whatever I can and however I can.
Well, for both of you, I did want to focus on the humans, not the plant, in terms of the conditions that this is useful for. Let's start with PTSD. How does it fit into a treatment strategy for that condition?
One of the things that I found across my research is that PTSD, when cannabis has been used in studies, we found that cannabis can actually help with the hyperarousal that actually underpins PTSD. So PTSD is this condition that you have all sorts of things going on, but when you learn that cannabis can actually help with anxiety and can help with the hyperarousal that is associated with PTSD, it becomes formidable against a condition such as PTSD. Now, of course, we don't have all of the answers about PTSD. We don't fully understand this condition on its own, but from the studies that I've come across, cannabis has done very well under this sort of condition.
Dr. Sarah, your thoughts on that and maybe some of the other conditions. Glaucoma comes to mind.
I think that one of the important things to remember when we're talking about cannabis as a treatment is that, it's our hope that cannabis is going to be another tool that is recognized as part of, overall treatment plans that may include, medications and non-medication treatments. And in terms of what we know about the conditions that cannabis-based medicines can be useful for, a lot of research has been published. Particularly, there was a systematic review that was published by the National Academies of Science, Engineering, and Medicine in 2017, and that showed that the research related to cannabis and chronic pain, cannabis and chemotherapy-induced nausea and vomiting, and some other conditions is very substantial or even conclusive. And for some, we're still awaiting research that will really elucidate where cannabis fits in as a treatment modality. But one of the important things that we try to stress through our program and by developing this program is that, cannabis medicine can be an important tool in our toolbox that we use to help people. And I love that, Katrina, that you talked about our program being human focused, because really it's the patient, patients who are at the center of, certainly of our program, really all of our programs at the School of Pharmacy, regardless of, whether we're teaching about research, about science, about therapeutics. It's really all, how do we improve the lives of patients?
Since medical cannabis was first legalized in Maryland, the dispensaries and other parts of that industry have been really busy, but I'm guessing that most people watching us have never been in one, have never tried any component of this, and probably have an image of cannabis being the same thing as marijuana and simply a drug that makes people high. How is it more complex than that?
And cannabis is a very complex medicine because, unlike a lot of the traditional medicines that we use, it's not a single agent. If you think about blood pressure medicines, you're looking at really a single active chemical agent, and this is a plant. So there are many different chemicals called cannabinoids and other chemicals in that plant that may have an effect on the human body. And humans respond very differently to cannabis. So it is an extremely complex medicine. There's a lot of interest now in components of the cannabis plant that don't cause these psychoactive effects. And so that is something that there's a lot of interest in researching. But I think it's important for people to know that we do look at this as a medicine, as a treatment for different medical conditions and symptoms that can improve people's lives, and that's how what we focus on in our program.
And Katrina, the idea is that this has been professionalized from the day where somebody had an illicit plant and they were using it, we'll call it way off label, to help with nausea or some other situation. It's now standardized, there are different strains, and you can get doses of things in the same sort of milligram measurements that we associate with other kinds of medications.
Mm-hmm. Yeah, and so what you're saying is essentially some of the things that we talked about in the program. That's what's called an effective treatment modality, where you have an entire treatment care plan where you have the dosage, where you have how often you're taking and what you're taking and what other components needs to be involved. And I mean, when you look at that, frankly, and you don't have that, you're using it recreationally, whether you've determined that you have anxiety on your own without a physician and you want to smoke cannabis on your own. That's self-diagnosis, that's self-medicating. But if you're using cannabis along with a physician and you have an effective treatment plan, you have an entire plan that is being watched, that is being guarded, that you are using, and you are remaining a part of the standard, then yeah, you're going to definitely see some results. That's the hope there. That's the hope that any clinician would have whenever they're seeing their patients.
Let me ask you this before I run out of time. If somebody's watching and they have a condition where they think this could be helpful, and they don't really know where to start. I mean, they know where the closest dispensary is, maybe wondering if whoever's behind the counter has any level of expertise. Where would you point somebody for reliable information at this stage in the development of this industry?
No, I mean, my recommendation is if people have a trusted physician or medical professional that they currently see, would be to start there. Not all health professionals know a lot about cannabis, but rather than looking on the internet for information, if you have a physician or a pharmacist that you trust and you have gotten other health information for, that would be the place that would be my suggestion for anyone as a place to start. Katrina?
And Katrina, you'll be hanging out a shingle at some point?
You better believe it. I'm all about building a brand and building myself. I became a part of the program with this passion, this emblazoned passion within myself to help veterans. So my next stop will be to go on and continue my education. I'll be starting a PhD program.
Our thanks again to Katrina Almonte and Dr. Leah Serra. And that is State Circle for this week. Thanks for watching and have a good night.
This program was made by MPT to serve all of our diverse communities.
In the summer of 1958, England is in a Cold War.
What do you think of this rocket that's gone up?
And Russian-born inventor Samuel Petrukin
Here goes.
is caught in the middle of it.
We work for the government.
The portrait of a family
It's idiotic to be taught how to sit.
in a world on the edge of change.
We want you to do something for us. To spy on my friends.
Summer of Rockets.
Tonight at 8 on EMS. Tonight at 8.
MPT. Be informed. Be entertained. Be inspired.
Queer and trans youth of color transformed the Christopher Street Pier into their own sanctuary.